Betty is one of the leading figures in IBD in the Northwest. I know her personally as a wonderful friend and an exceptional professional. I think Betty has been such a huge advocate for patients and a major supporter of the Crohn's and Colitis Foundation. And I can't think of any single major educational event in the Northwest and beyond, nationally and beyond internationally, that Betty was not involved in. So I'm just beyond delighted to have Betty present this to us today. Thank you.
Wow, now I have to put up with that. I thought maybe you asked me to come because no one else wanted to present this subject. First off, I just want to say thank you to all of you for being here. I mean, this is what it's really about. I am honored and pleased to see all of you in the audience here learning more for your patients because that's what improves outcomes. You are the ones with the first touch. You are the ones educating the patients. These guys do a wonderful job diagnosing patients, but we all know who educates them and talks to them on the phone every day. So thank you for coming. And Dr. Lee and Dr. Wabe and Dr. Afzali, who's not here, and Paul Strunk, who put this together, thank you, because they were persistent. You know, the last couple of years we haven't had a nurse and nurse practitioner PA event because there was not funding and nobody could organize. And so I just want to say thank you from the bottom of my heart. This is always what I wanted it to be, is something to this extent. And I'm very proud, and you guys did a wonderful job, and thank you. So there is no golden key, no, I don't have a crystal ball. I always wanted one, but I have not been able to get a crystal ball. And I have disclosures. I no longer speak, but I have been a speaker for Abby, Janssen, Takeda, UCB, and Salix in the past as well. As most of you know, I'm no longer seeing IBD patients, and it was a hard decision, but I've chosen to go into another field. But this still was a passion, and so I'm very pleased to be here today. So we're going to talk about necessary tools to get authorizations. I wish I could give you a toolbox, but I think that those of you that do it on a regular basis, you've learned what those little keys are, and I'll tell you what I found and what I've taught to other people in the past. We're going to talk about the state law because there's changes going on, and there'll be more changes coming out as of 2020. And I think that finally it's going to be easier for us. Again, you have to know those little key words to use, and there are some clues. And then we'll talk about how to deal with the denial. Half of my day sometimes were spent on the phone with peer-to-peer and writing denials because I did that for our whole practice. And if you don't know, Washington Gastro had 64 gastroenterologists, so I was doing all of their denials and all of their peer-to-peer reviews for biologics. So I've done a few of those. So drug costs in the U.S., it's been estimated that greater than 40% of U.S. take at one medication and greater than 50% take at least 3 medications, so that's an average. Centers for Medicare and Medicaid estimated $325 billion was spent on medications alone purchased at retail pharmacies in 2017. And the Crohn's and Colitis Foundation in May 2009 published an article stating that the average IBD patient spends more than 3 times on IBD patients. Most of these expenses were in medications and comorbidities and ER events. Non-adherence leads to increased costs. We all know why that is, right? Non-adherence is estimated about 17 to 45% in IBD population. It's really hard to get an estimate because sometimes these patients kind of fall away or move or go to another practice. Non-adherence has been shown over the years to increase costs with hospitalizations and ER visits, and we see that on a regular basis. Prior authorization is required because the insurance company has decided that these medications are costly, they may be fairly new, and that it has to be authorized by the insurance or they're not going to guarantee payment. And we don't want our patients being stuck with the payment on these medications. Do you guys know what these medications cost a year, right? I would say on average $35,000 to $50,000 a year, depending on where they're getting the medication, whether it's an injection, an oral medication, or an infusion. They're very expensive medications. It's been estimated that close to 70% of all medications that get denied at the pharmacy level that need a prior authorization, and a significant amount of patients never go back and pick up their medication, or they wait till the next time they see a provider, and that can be months, 3 to 6 months before they see someone, and they can be very sick by the time they get back and get on the right medication. Prior authorizations also cost the providers. You can ask any provider or physician or physicians group, the University of Washington if you talk to anybody, what is the cost in your office? How many people are sitting there every day dealing with pre-authorizations, right? Medical assistants to RNs spend 20 to 100% of their time doing PAs. Where I came from previously, we had 3 people at any one time working on PAs in the office. A lot of those were for things like simple GI drugs like antacid medications. But a lot of these are biologics too, which take a long time. You get someone on the phone, it takes hours, right? You can wait 20 minutes, they'll put you on hold, you talk to one person, they transfer you to another person. I think one time we counted 5 or 6 people that we were transferred to and finally get back to the same person that you initially were talking to, because nobody knows what they're doing or who's supposed to be doing what. Takes a lot of time. Peer-to-peer calls, they try to catch you when you're free, right? Well, Dr. Lee, how often are you free during your clinic, right? You sit there just waiting by the phone for a phone call. And are they there right away? No, they go find you, and then they go find the provider that's going to talk to him. And by that time, he's already got another patient in the office, and he's behind, and he's late, and he's double booked. And so no, these aren't things that are easy to get done in a day. Patients also are not able to pick up the medication they were prescribed, and now they're calling you back because they're sick and they haven't picked up the medication, they're wondering what's going on. That's also another phone call to the nurse or the MA or whoever's answering the phone. Then there's a cost with additional Medicare, medical costs to the patient who doesn't get that medication in time. So now we got them on steroids, they're in the hospital, they may end up getting a surgery before they ever get their medication. And the cost to an outside company to process the PAs are somewhere between $2,000 and $14,000 a year. So if you actually have, and a lot of groups do now have an outside company processing this, there is cost to that. Somebody does pay for that. This is a case in New England, which I just think is interesting because I think it tells or talks to the importance of what this is and what we do every day. The patient was given an RX for an anti-seizure medication. They started the medication, then they were presented with their second prescription to the pharmacist when she was told that it now required a PA. We've all had that happen, right? Someone gets started on medicine and then all of a sudden insurance changes or their prior authorization for the insurance changes, or all of a sudden the insurance realizes what medication they're on and now they want a PA. So they were directed to call their provider. The stepfather did contact the provider's office several times between July and October that year. The patient died after experiencing her next seizure. Her estate filed a lawsuit against the provider and the group practice and the pharmacy who denied the prescription. So, I mean, that all makes sense as to why we're doing this and why this is so important. Prior authorization in Washington. So there's been some changes. The AMA in 2018, this is the new law, State Bill 5347, if you want to remember that. So starting in November of this year, plans must have a current online process that provides providers with specific info needed to determine a service as a benefit under the plan. The response time for non-urgent is supposed to be less than 5 days, and for urgent, which my patients that came for a biologic were urgent all the time, it should be less than 2 days. And they must allow submission of PA at all hours, 24 hours a day, and no PA shall be required in emergency situations. A PA cannot expire sooner than 45 days of approval. So that's some of the new laws coming about. Denials must include a specific reason, which I think sometimes helps you when you're finding the additional paperwork or information that you need to help with that denial. And they must also include the enrollee's right to appeal. So the patient has to get a letter too, which often makes it confusing because then the patient doesn't know what to do. They must include evidence-based clinical review and must be accessible to a provider. I can't tell you how frustrating it is to get a denial for something and they have no clue as to what the evidence-based or the data is based on the medication or even the protocols that we have. PAs must be staffed by healthcare professionals who are licensed, certified, or registered now. So that's all changes instead of just getting someone on the phone who pushes buttons. The plan must accept any evidence-based information. So I used to have a file that somebody helped me with, and basically that file included every bit of data that I could find on that drug. And when we got a denial, we sent all of that paperwork to them, because when they get a stack of paper, they often don't read it and they just approve it. This law applies to medical services, though, and infusions are considered a medical service, not a prescription. The next step therapy law, which is 6233, will be initiated in January 2021, so you have another year still. But on this, health insurers has based step therapy on clinical practice or guidelines that are peer-reviewed. So that means our peer-reviewed documentation through AGA and ACG will now become standard of care. So we no longer have to go through whatever the insurance company tells us is standard of care. The patient has to have access to fair, transparent, and independent process for requesting exception to step therapy if the provider deems appropriate. And the insurer shall respond to reception within 72 hours or, in emergent situations, be asked to respond within 24 hours. If they do not respond, it's automatically approved. That's going to make all of our lives significantly better. So we've got another year, a few months. Like I said, I don't have a crystal ball. I always wanted one. But the patient doing PAs in your office should know a little bit about. So whoever's doing it has to know the diagnosis. And they have to know in and out of the diagnosis. They have to know where to find the diagnosis. They have to know what the differences are in the diagnosis. They need to know which medications are used for IBD, generic and trade names, obviously, in the categories. They should have a copy of the guidelines, because a lot of times sending the guidelines will help these things get approved. And they should have a list of insurance medication preferences, because sometimes you can give a medication, a biologic, and it really doesn't matter. You just want to get them on drug, right? So it doesn't matter which one I give them first. Remember, the first drug is always the best drug. So sometimes it's helpful to just see what the preferences are. They should have copies of the studies for off-label use as well, because often those studies are done, and that does help. And they should also have some knowledge regarding the state laws. And so I think that's important for anybody. Persistence has got to be your goal. You've got to have someone who's strong and doesn't get on the phone and say, okay, we'll do that. No, you have to have someone who says, persistence says, this is what the physician or provider wants for the patient, this is why, and this is our data that we have. Also, if you get a denial, make sure the patient's aware of that, and check in with them to make sure their current status. If they're really sick and they're back in the hospital and you don't know that, and you're waiting still another couple of weeks for denial, you're not helping anybody. Read the criteria for the denial so you understand. A lot of times it's hard to find. It will be in very fine print on the second page. Figure out what the criteria was, because sometimes it's something like they need to pay their copay or something, and something silly that doesn't even really pertain to the drug. And make sure you have request peer-to-peer all the time. I always request a peer-to-peer, and that doesn't mean that they're going to put me with a general practitioner somewhere out in Utah that doesn't know anything about IBD. I want to speak to a provider who takes care of IBD patients. And make sure you have your guidelines and studies needed to make your point, and you know what those are and you understand those. And make sure that the peer, again, knows your specialty, and I always asked them their title. They didn't like that very much, but especially when I said I was a nurse practitioner. I'm like, who are you? If you do not get approval of peer-to-peer, you still have a chance to appeal. The patients need to know that. Make sure you have a pre-printed appeal letter already, and there's several of them on the Crohn's and Colitis website. Include every piece of data that you can. Like I said, they don't like all that faxing of paper. Save a copy and date it so that you have, because a lot of times they say they don't get the fax, or they say, oh, we didn't get that information. You have, no, I sent it on this date, and I have a copy of the fax information. Make sure the patient is aware, again, and tolerating whatever treatment they're on. That's always important, and don't forget about that. And always write urgent on the appeal, so there's always a chance that, if the patient gets hospitalized or surgery, you've made that point. Again, going back to that lawsuit, right? So there's no magic or crystal ball. Just be prepared, present the data, and be persistent. And good luck to everybody who does this every day. Thank you.